So next up in our rapid fire presentations is Dr. Andrea Iaboni. She's going to present on some of her research. She is a geriatric psychiatrist and a clinician investigator at Toronto Rehab, and she's the research lead for our geriatric rehab program. Dr. Iaboni is a Rhodes Scholar and did her doctorate in clinical medicine from the University of Oxford and is assistant professor in the Department of Psychiatry at U of T. Her research really is, as you're going to hear from her, is in the area of innovative technology for dementia care with a focus on clinical evaluation for prevention of falls risks and other neuropsychiatric symptoms such as restlessness and agitation. And she works closely with our artificial intelligence and robotics team at Toronto Rehab, and they've developed a number of technologies she's going to talk about. Dr. Iaboni.
I'm really pleased to be here in my home turf speaking to you today about the research I do in dementia care. And really pleased to follow Dr. Fargo. He gave a great introduction to the idea of dementia, what dementia is. And it was really helpful actually for you to explain the little squiggle, because I'm really embarrassed that I didn't know that that was a head and a flask. So now I know, and that's great. So I'm a little bit in a slightly different direction from what you've heard so far. What I work is not so much about preventing the disease itself, but preventing some of the suffering that goes along with the disease. I work in dementia care rather than dementia prevention. So that's where I'm going to be leading you today a little bit, is talking about my perspectives about dementia care and some of the research we do from this frame of dementia rehab, where I work here in this research institute that's all about rehab. And so that's the perspective and the frame that we use. And dementia rehab is fundamentally a very optimistic frame, the idea being that we work to support people in having optimal function within their dementia, that they may have some deficits associated with the disease, but that people are remarkably adaptable and that you can help people with dementia live with their dementia and thrive with their dementia with the right care approaches. This is, I kind of think about rehab as like a temple to the adaptability of human beings. People come to rehab after having had catastrophic injuries, but then learn to live with those injuries and the consequences of those injuries and carry on and have very fulfilling and meaningful lives. And so applying that same frame to people with dementia. And so the focus is really on preserving function, preserving autonomy, get that word out right, and really addressing people's dignity. A lot of the dementia care, so I'm a clinician as well as a researcher, and so I can tell you a little bit about what dementia care looks like in the real world right now. And a lot of it is very reactive, right? We do symptom management, we manage crisis, we try to manage risk. And the result is often not what you hope when you take that kind of approach. So an example might be, someone with dementia living at home who has a tendency to wander and maybe is a falls risk, and so family members say, sit here, stay, watch this television, and of course people limit their activity then. They don't go outside very much, they don't get any sunlight, and then, they go to bed at night, they've been napping all day on the couch, and then they don't sleep very well at night. They have a bad night's sleep, or the caregiver has a bad night's sleep as a result. Things are going a little bit off, and they turn up at the doctor's office, they get prescribed a sleeping pill, which, by the way, they don't work very well. The next night they take the sleeping pill, they go to bed, but they wake up in the middle of the night a bit drunk, they fall, they fracture their hip. You can see the way that which this kind of reactive way of managing dementia is actually can lead to actually worse outcomes. So dementia rehab is about actually adapting to some of the changes, finding ways to support people to live a meaningful life, to problem solve around the deficits that people might have, and really about supporting function in people with dementia. So that's the frame that I use in my research. And there are some important big barriers to people with dementia living well. And this is, I take this from the disability rights movement, right? Because I think about dementia as fundamentally being an example of a disability in the same way that you might be in a wheelchair, or you might have some limitations, other kinds of disabilities. But the barriers to living well come in these sort of categories. And so attitude is a big one. So that's about like the stigma that people have about people with dementia, the people's ideas about what they can and cannot do, and that can serve as a real barrier to people living well. Institutional barriers, the ways in which our institutions discriminate against people with cognitive impairments. You may not think about that, but a good example was illustrated by the work of my colleague, Dr. McGilton, who found, she's there at the back in the corner, that found that people who had dementia weren't being admitted to rehab hospitals after they had hip fractures. There was just this idea that people with dementia couldn't rehabilitate. And so there's a really good example of an institutional barrier to people with dementia. And so she, was able to help work overcome that. And where I work is really in this middle area, which is around environmental barriers to people with dementia. So, that's the same the way that curb is a barrier to someone with a wheelchair. An environment that is overly complex or stressful or that doesn't really accommodate somebody who has cognitive impairment presents this barrier. So that's where I work in dementia rehab. So the tools that we have, to address attitudes, we work in terms of education. To address institutional bias, we come up with better care models that actually support people with dementia. And when we work in addressing environmental barriers, the kind of two areas that I'm working in is in assistive technologies and coming up with adaptive environmental design to help people with dementia live better. So I have a number of different projects that I'm working on, and before I get into talking about some of the work that we're doing, I want to acknowledge the research team here at Toronto Rehab, the scientists, the trainees, the future researchers who really do a lot of this work and help move this forward, and then also to recognize those people who have the vision to support this kind of work, including Walter and Maria, and also the Alzheimer's Association who have supported us. So I'm actually going to focus in on two projects rather than sort of the whole body of research, because I want to get into a little bit of depth into why it is that we do these work and what this work looks like. So the first project, actually, before I get to my projects, I actually have to also acknowledge the clinical unit here, where a lot of our research is done. So this is the specialized dementia unit here at Toronto Rehab, and it's a really unique place. It's probably one of very few academic dementia units in the whole world. And it's a unit that's really been developed as this living lab. It's full of different kinds of sensors. We collect huge amounts of clinical data about the patients who are on the unit. It's also a really unique unit by the quality of the care that they deliver there. So people come onto this unit with a really high symptom burden. This is called the neuropsychiatric inventory, and so anything higher than 40 is considered a severe symptom burden. And so in blue are the scores of the last 100 patients who were on this unit, you can see that there's a very high burden of symptoms. And then when people leave, they actually have a significant improvement. Those are the lines in red, so more mild to moderate symptoms. And so that's really a testament to the comprehensiveness and the quality of care on the unit that really allows for this research to happen. So I had to acknowledge them as well. So I'm going to start off by talking a bit about the Ambient Project. And this actually was funded by the Alzheimer's Association, and it's also supported here by Walter and Maria as well. I guess a good way to start is to ask everyone here to reflect on the last time you woke up feeling a bit crummy. I don't know, maybe it was this morning, maybe you had a few beers watching the Raptors game, I don't know. And imagine you're not feeling very well and you climb out of bed and you're walking to the washroom. Think a little bit about how you walk in that moment. Maybe you've had the flu, you just don't feel great. Does that look like your normal walk when you're getting from your bed to the washroom? It's different, isn't it? When you feel crummy, you walk more slowly, you're a little unsteady, you wobble, your balance is off. And really what we know now is that walking is actually a very sensitive marker of how well someone is feeling. In some ways, people have called it the fifth vital sign. But walking is a little bit harder to measure than blood pressure or heart rate, right? How do you track someone's walking? And so it's never really been used in this way. And walking in people with dementia is particularly sensitive to how someone's health is. People with dementia already are experiencing some deficits in their motor control, in their balance, and their coordination. And so something like an infection or a new medication will really tip them over the edge in terms of changes in their walking patterns. And so we think about walking as being a really interesting marker for health status. And it also tells us something about their risk. It also will tell us about their falls risk. And so what we decided to do here was to develop a system that we could use to actually monitor walking, monitor it like a vital sign in the environment, and to help us detect when someone's walking patterns were changing or more unstable. And so the rationale for that from a dementia rehab perspective is that mobility is really important. We want to maintain people's mobility, and we want to do it in an active way. We don't want to stop people from falling by making them sit. We want people to move. And so to be able to detect when someone's walking is getting worse, that gives us an opportunity to intervene early, to actually intervene from a rehab perspective. So this was basically the idea behind the Ambient Project. So this is how the system works. We have it set up in a corridor. This could be anywhere. This could be a corridor in somebody's home. It could be in a retirement home, or in this case, it's in a long-term care facility. And so we have these little tags, the kinds of tags that you get, like security tags on clothes that you snip off when you buy your. So we have tags like that, and we iron one of those tags on the pants of the person who we're tracking. They walk down the hall, a little sensor picks them up, and then it turns on a video camera. A plain old video camera records them walking down the corridor. From that video, we use this fancy stuff. This is not my area so much, the more the engineers do this for me, the computer scientists. But you take the video and you break it down frame by frame and use computer vision to track all the joints, and then put it all together. And so you can see that picture there with all the green dots. That's the person's, I'm not sure which joint that is. That might be their ankles. So those are their ankles, frame by frame, tracked by the computer. And then you put that data together, and you can get this plot where you can see the left ankle, right ankle, left ankle, right ankle, step by step as they're moving down the corridor. So from that, we can get some information about how they're walking. And that we don't just do that once, but we do that every time that person walks down that corridor. And so over time, you build up a profile of what someone's normal and natural walking is like. So you can see here, this is someone over many days. They're walking, and then you see towards the end that something's gone a little bit funny with their walking. Some of their variables are a little bit outside of range. And so what the idea of this is that you can start to tell when something is changing in someone, and then gives you an opportunity to investigate and find out why. And so one of the interesting results of this study so far is that we found that there's one particular measure of walking that we can detect using this video camera that is particularly important and predictive of falling, and that's a measure of gait stability. It's something that's called the margin of stability. The basic idea is it's like a measure of your wobble. It measures how well you transfer your weight from side to side as you're walking, and how close your weight is coming from exceeding your limit of support. So if you get too far off to one side, then you have to take a step to recover your balance. And so, good stable walking, you do a pretty good job of keeping your weight in the middle. And people who don't control their weight fall. And so we found that what was true, that the margin of stability was our best predictor of who was going to fall in the next 2 months. And what's actually remarkable about this is that, first of all, we've got no other way of measuring margin of stability. To do this, typically you have to be in a fancy lab with fancy equipment. But this is just in a corridor with a camera. And the other is that we can predict short-term falls risks. So not like whether someone's going to fall this year, which is what a lot of falls risk predictors do, but whether someone is going to fall soon. In this initial study, it was in the next 2 months. But since then, we've done some more modeling, and we've been able to show that we can actually distinguish falls in the very short term, like within the next few days. So one way of doing this, we were able to divide them, just a very simple model, using the margin of stability, divide people into high and low risk. And so you can see the black line, that's the high risk group. And as that line goes down, that's the number of people who are fall free still in the study. And so people who were in the high risk group, based on how unstable their walking was, they had a 20% chance of falling in the next 5 days, a 1 in 5 chance of falling in the next 5 days. And in the next month, 60% of that group, almost 2/3 of them had fallen. So we have this marker now of someone who's really truly high risk, who's really in some more imminent need of intervention. And we have also used this data now. So that's just using a baseline measurement, like a single measurement of margin of stability to divide people into 2 groups. But we're collecting this data every day. And so now we can look and see, using the last 4 days of walks compared to the weeks before that, we can actually identify correctly 75% of fallers in the next 6 days. So for them, we can really say that this person we think is going to fall with high probability in the next 6 days. So this work was based on the specialized dementia unit and a collection of data over a few years there. But really what we have to do now is look at a population over a longer period of time and a larger number of people. Oh, it's blocked my words for some reason. But so we've got Ambient now installed on 2 floors at a long-term care facility called Lakeside, which is affiliated with Toronto Rehab. And we're developing some more increasingly sophisticated models and early warning systems for changes that are happening, as well as starting to develop some of the rehab interventions to deliver when those early warnings are received. So the other project that I want to tell you about today is a little bit earlier in the development process, but I'm really excited about it, and so I'm going to share it with you today. And this is funded by AgeWell, as well as Walter and Maria Schroeder, and it's called the STIX project. And so I'll explain what STIX are. So the idea is, well, I'll take one step back. So one of the most common worries that we have about people with dementia is that they might wander or get lost. But we're very fortunate now that we have a lot of technologies that are designed to locate people. There's amazing innovations in GPS and other sorts of things. And so what this project really is about is using some of that location data, not so much to find people, because that's relatively simple, but actually using this location data to tell us something about how people with dementia are doing in other symptom areas. So STIX stands for space and time. That means space-time indices. People move in space and time. Space-time indices for clinical support. So using location data, using the information about where people are to tell us something about how they're doing. And the way that we are going to do this is using something called real-time location system. So that's a system that helps track where people are in their environment over time. And the basis of this is that patterns of movements are really clinically meaningful. Where people are and how much they move tells us things. An example would be using where people are and how they're moving to tell us something about their mood. So we know that people with depression spend less time with other people. They spend more time on their own. They walk more slowly. They have disrupted sleep. They spend less time in the dining room. There are all these different things that would tell us something about someone's mood and their engagement in their environment that we can measure from how they move around. And so the idea behind STIX is using this sort of wealth of location data that is being generated as we care for people with dementia to then actually give us these clinical insights and to help us better support people with dementia. And so we have this system that we are installing on this unit here that I just told you about, the specialized dementia unit that will help us to generate this data. We're also working with long-term care facilities in Ontario that already have systems like this installed that generate heaps of data about where people are and how they're moving. And we're going to learn from that how people's activities levels are, what their rhythm, circadian rhythm is, how much social interaction they're getting, what their gait speed is, what their gait path is. And this last part is really important, is really understanding how people with dementia are interacting with their environment to allow us to come up with better adaptive designs. So this part is sort of the next stage of the STIX project. We're in the process of installing the system and generating all of this location data. The next step is starting to intervene to help adjust the environment in ways that will, and then evaluate the effectiveness of these interventions. So our environmental design and dementia project is really about evaluating best designs that help adapt the environment to the needs of people with dementia. And actually, to really focus in on design solutions that are practical, cost-effective, and impactful. Because, people don't have necessarily the resources to completely redesign their house, to do a massive renovation, to tear down walls, to make things, to adapt things like that. But maybe it doesn't need to be like that. Maybe the intervention is as simple as a curb cut. It could be as simple as improving lighting. Lighting is extremely important for people with dementia. It helps with their sleep-wake cycle. It helps with mood. And so we are looking at ways of improving the lighting on the specialized dementia unit. Comfort and function in the hygiene care, in the shower area, turning these areas into places where people can actually participate more in their own care is a really important way to support autonomy and dignity in people with dementia. And finally, wayfinding, finding ways to adjust the environment so that people with dementia can find their way to their room, can find their way to the bathroom, are very impactful ways of improving, adapting the environment to care for people with dementia. And so our system is designed to be able to implement these kinds of design changes and then see what their effects were. How much more quickly can someone with dementia find their room, or do they find their room more easily once we've implemented some of these changes? You can see on the top, up corner there, that's what the specialized dementia looks like right now. The unit is a rehab unit. It was built here in the rehab hospital, and it wasn't developed specifically for people with dementia. And so our hope is that with the support of funding agencies as well as the foundation, that we will be able to start moving towards creating an environment that's really optimized for people with dementia. And so, in summary, dementia rehab is this very optimistic frame for the dementia journey. It's really about confronting barriers, helping people achieve optimal functioning by adapting the environment to their needs, adapting our care strategies to their needs, allowing people to live, tolerating people taking risks, and doing what they need to do to provide meaning and purpose to their lives. And then building a research program that's building the evidence for the environmental design strategies that we need to support this.